Okay, good evening. This is 7:30 now. So we are starting the program. So we are almost entering the last phase of our certificate program in infectious diseases. Almost few classes only pending. In another 2 to 3 weeks, the certificate phase is getting over, and you need to prepare for your examinations as per the instructions of API now. And the standard instructions, instead of putting in a name and getting your attendance, we don't want it. You need to interact with the faculty whenever a faculty asks for questions or something. You need to type in your chat box. Right now, people start putting in the name. Don't put your name in the chat box for attendance. Please interact with the faculty, raise relevant questions to the faculty or to the moderator so that you can get the attendance. People are raising the questions and people are interacting with the faculties and moderator are going to get the attendance. That's the routine in this program compared to the other programs. So you need to interact with the faculty. That's a requirement. And please, people who are, this is like a Zoom meeting only. This is not Zoom webinar, so we are not able to mute yourself. Please mute. It won't interfere with others listening there. Some of the people inadvertently are opening up your audio column, so it interferes with other people. Please mute yourself. All the things go through the chat box only there. Whatever questions you are putting in, we are going to ask the speaker. So with this general instructions, it's my pleasure to introduce Dr. Rajalakshmi. Rajalakshmi is well known to me for the last 10 years. So she's a senior consultant and ID physician at KIMS Hospital, Trivandrum, and she's a leading light in infection control and preventions, and she's a SHE ambassador also, and she's active participant of, she's active executive member of SITS and doing a lot of infection control prevention activities, also leading Kerala, and he's doing a lot of SITS activity, as well as webinar activity, and particularly antimicrobial stewardship and infection control is a priority. And she's a very good speaker also, apart from her qualifications and other things, she's a very good speaker. And today she's going to discuss about healthcare associated infections and device associated infections and what are the routes of transmissions and infections. This is a need of our, when COVID is start resurging, this is not only COVID, any infectious diseases or any pandemic surging, unless you know the infection control or hospital healthcare associated infections or device associated infections or routes of transmission, it's a bit difficult for you people to control it. Unless we control, treatment is easy for me, control and prevention is most difficult for us. So this is what she's going to discuss. Without further ado, I don't want to stand before you and Dr. Raji. Raji, stage is yours. And thanks for accepting our invitations. And in spite of despite your busy schedule and spending in 1 hour with my PGs. Thank you.
Thank you so much, Dr. Suresh. I think it's indeed a pleasure when you asked me to talk on something which is very close to my heart, that is antimicrobial stewardship and infection prevention. Because you know that hospital is an environment where there is a highest risk of infection transmission than in the community. And it is always associated with a risk of resistance, or drug resistance also. So I understand that quite a few are residents. So actually I have introduced some of the questions and answer type, which are something very basic. And as we go on to the second half, it may be a little more focused on device-associated infection, which again, it's important from your practice point of view, because most of them will be going to ICUs and so on. So you can put your chat box, but I won't be seeing the chat box in between, but we'll try to answer at the end of the session. And so the topic that I'm going to present today is need of the hour, the HIV prevention. It's a huge topic. I have touched upon only a few aspects, but I'll be happy to answer questions later. And I will start with this. If you can identify this person and write whatever you know in the chat box, we'll try to answer. Anyone or anyone can do that in the chat box. And let's see how it goes.
Your utterance depends on this type of interactions only. Please go ahead and interact with that.
So I'm seeing the chat. Okay. Florence Nightingale. Yeah. Not Sister Mary. Florence Nightingale, not Typhoid Mary. It's Florence Nightingale. So what is she known for? No, she's a brilliant lady. Can you tell a few things that she did? Anything that you know about her? Yeah, largely do no harm to the sick. Lady with the lamp, yes. She's a nursing stalwart. Yeah, sanitation. Yeah, exactly. Sanitation measures during Crimean War. That's when she was known as a lady with a lamp. Yes. Yeah. So that's excellent. Okay. This is important because just like we know many of the doctors who have contributed to infectious disease, this is a nurse. She's a nurse who is contributed to infection prevention in many ways. And if you look back, we are doing a lot of surveillance, how many discharges, how many deaths and all this. These are all surveillance. But she has done is way back in 1800s. Okay. So this is her statement. What is it? It may seem a strange principle to enunciate as the very first requirement in a hospital that it should do the sick no harm. So it was way back in 1959. She is called the Lady with the Lamp, founder of modern nursing, renowned social reformer, statistician, pioneer in infection control measures. Okay. So even at that, I mean, 150 years ago, she has made the importance of keeping a statistics of who went on to improve, who died, and so on. And these are still available in paper form. So I should say she was the first one to introduce surveillance and statistics to us. So, so today's focus will be on the chain of infection transmission and how we are going to prevent it. And it's a multimodal approach. As you can see, this chain starts with microorganism, which can be a bacteria, virus, fungus, or parasite. And there is what is called a reservoir or the source for any of this. Inhabitant, it's a reservoir, is a habitat for the organism to grow. It can be human or animal, which are living objects. It can be non-living, like air, food, soil, water, and equipments and environment in the hospital where the bacteria can multiply. And these are called the source or the reservoirs. These terminologies are important. Port of exit is, it can be just you are touching an object and then you are carrying that bug. That can be the port of exit. Or usually it is a secretion like saliva or excretions like urine or feces. That's how it gets exited from the body. Modes of transport is by contact, as I said. It can be hand, it can be droplet, can be airborne, which is a small droplet particles, or it can be vector. Vector means it is an insect or something transmitting, or fomite is inanimate objects. Then it enters into another human. It's called the portal of entry, which is usually through the mucosal lining or open wound, oral respiratory tract or urinary tract. And this enters into a susceptible host to cause a new infection. If you are young and you are able to get away with that, probably you may not get infected. The colonized bacteria will die or get transmitted and it will not harm you. But in a susceptible host, who is very young, like newborns or elderly, and those with chronic disease, neutropenic, immunosuppressed, malnourished, this can cause infection. So this is how the chain of infection happens. And it's important to understand because there is a lot of infection control measures that can happen with some of the stages, and in some stages, it's an antibiotic and treatment that will help to break the chain of infection. As you can see, the reservoirs where infection prevention can help. Port of exit, yes, if you do a good hand hygiene or wear mask, probably you may not be contaminated. You may not get contaminated from the person who is sick or carrying the infection. And you perform contact isolation precautions and other things, then again, you will not be contracted with the infection. And then you will not be transmitting to the next person. And in a susceptible host, if a reinfection occurs, then it is by decolonization, where you use chlorhexidine bath, or you give treatment to kill the bacteria and treat him so that he doesn't transmit to the next patient. So if a susceptible host is not treated or you don't follow infection prevention, again, you'll be transmitting this to multiple other patients. So unless you break the chain, the infection transmission goes on, and we never know because these are all microorganisms. Unless you have an outbreak, you may even not even suspect. And it's also important that a patient who's discharged from the hospital actually carrying to the home and the caregiver become part of this. So then it goes to the community. That is how even in India, the drug-resistant infection is largely even in the community, because the discharged patient reach home and our water bodies, our environment is highly polluted because of the feces and the urine. And so many contamination methods that is happening, food contamination and so on. So the breaking the chain is very, very important to prevent infection transmission. and also to prevent development of drug resistance, because this drug, and if a patient is sick, patients having a drug resistant bug, again, the transmission happens in the same chain. So again, this is another diagram which simply explains what I said. So if this is the bug, the agent can be a bacteria, virus, or parasite, and the reservoir can be human or an animal or a water body or any other reservoirs. And the chain of infection transmission is either by contact, droplet, or airborne. I'll talk about what is droplet and airborne in the next slide. Or it can be a food or a vector that can cause infection transmission, and it reaches to a susceptible host and causes infection. So in the hospital, we are more, in the community, this can happen, but in the hospital, we are more focused on this. See, in the hospital, the patient is admitted with the infection, then the transmission is usually due to contact, droplet, or airborne to the next patient. And with COVID, everyone became more aware of infection transmission, what is a droplet, what is an airborne, how to prevent, what is a PP, and so on. So this is an excellent slide. Again, I will give you an understanding of how long the bug can stay and how to take care of yourself and how hand hygiene should become a habit. So though we know COVID is mostly droplet and droplet nuclei, what is these differences? If an infected individual's cough, the droplets are bigger particles which can not cross beyond 3 meters and falls at the feet or the ground, and it doesn't spread or remain in the air for long. But droplet nuclei, as you can see, is a smaller thing and it can remain in the room or in the environment for a larger period, and the other person, healthcare worker or a patient, bystander, or anyone who enters, they are at risk of inhaling and become susceptible. So especially if the patient is coughing and patient is intubated and suctioning or bronchoscopy, all those instrumentation which can produce droplet nuclei or aerosol, they are at risk of inhaling even if at a distance. So this is same with influenza, this is same with measles, TB and all, which are all usually airborne. So so that is how we want to prevent the change of transmission by cough etiquette, where should you ideally cough? Into the elbow, not to the hand, because your hand gets contaminated. So coughing into the elbow, wearing a mask, hand hygiene, and improving the ventilation so that the airborne or the particles actually is diluted into the environmental air. Or if there is a suction or a vent, which is called the negative pressure, again, it will suck and actually it will let out into the either into the environment or through the filter for recycling. And look at this picture. It shows that how long a SARS-CoV can remain in the innominate objects. It varies from hours to even days. So that is how our principle of infection prevention should become a habit. So when you suspect, you don't know whether the patient is free of infection or so, whether he's coughing, his high-touch surfaces or his linen or bed is contaminated, we don't know. So hand hygiene actually reduces the bioburden, and wearing gloves in certain cases is important to actually prevent ourselves from carrying the infection to ourselves and to the next patient. So to summarize, infection prevention is a triad, and it is actually a interaction between the host, the environment, and the pathogen. And based on how close you are with the pathogen and the contaminated environment and how sick or immune compromised a host, they can be a carrier or they can fall sick due to infection. So next question, it's again for you to answer in the chat box. Single most effective method of controlling hospital-acquired infection is isolating infected patient, screening patients for infection, hand washing, wearing a mask. So let me see the chat box for your answer. It's 3 hand washing, 3 4 hand washing, random. Okay. Most of them are hand washing. Yeah. So okay, how? Let me just. I have not put the question. How strongly do you believe in hand washing? Strong, no, or in between? You can again reply in the chat box. Strong. Very good. So how complaint are to hand wash? Do you perform hand hygiene every time as per the opportunity that is put forward by the WHO? Do you do every time or do you miss 70%? You can range between 50 to 100%. How complaint are you? 60%, 100, 70, 50, great. Yeah, some are very truthful, 30, very good. Because if you know where you are, then if you start billing, you may perform well, okay? If it becomes a habit, probably you may become 100%, okay? So that's good, okay. So yes, nursing should be performing because more than doctors, nursing come into contact with patients often. And during audit, we find that nursing compliance is better in hand hygiene than doctors, especially in the ICU. We don't know the exact figure in the wards and the rooms is when we get in because it's audit opportunities are less. But when you see the ICU, hand hygiene performance of nurses are better than doctors. Usually. It may vary from hospital and ward to ward. So, yeah, you know, again, this is a beautiful historical picture. Again, do you know, how many of you know Semmelweis? And what is he associated with? Okay, somebody says the skin is affected by, yeah. So again, that you should be careful. If it's caused dermatitis, you should switch the chemical or go for soap or you have to find another alternative disinfectant. Yeah, pure. So he brought in the concept of hand washing. Again, he brought down the puerperal sepsis in the ward that he brought in the change. Okay, so human is a microbiome. We are filled with microbes. If you know, around 2 to 10 million bacteria is there between our fingertip and elbow, which is the commonest point of contact with the patient. Okay, so infection control precautions are specifically designed to prevent transmission of pathogens within the hospital. And that is how the infection control team works, which is usually run by nurses, led by a doctor who can be an infectious disease doctor, physician, or a microbiologist, depending on the availability. So, this is about transient and resident follow-up. Okay, what do you think? Hand hygiene. I have already given the answer. What is the difference between transient flora and resident flora is by doing a hand wash, your microorganism superficially is usually cleaned and removed. So microorganisms that are normally found in the skin that are acquired through contact with the environment is called the transient flora. And hand washing with soap and water is effective in removing this. Okay, because these are loosely attached. Okay, mechanical washing combined with detergent like cleaning is good enough. But resident flora is little more deeper. It is again normally found in the skin. It's not abnormal. And it's usually helpful to protect from overwhelming multiplication of the harmful organism, especially you find in the mucosal surface, you find in the genital surface, but even on the skin. So by hand washing, these are not usually removed because these are deeper. And usually by doing using the hand rub or the hand sanitizer will help to remove this resident flora. This is more important to achieve reduce burden bacterial load before any aseptic procedure and in between patients where you can carry organisms. So WHO has given us this beautiful diagram. Again, you'll all be knowing, especially after the COVID, you will be master of this. So can anyone or all of you can try and tell me, as you can see, there are 5 steps before touching the patient. Okay, and before doing any aseptic procedure, after touching body fluid, after you have an exposure to the body fluid like vomiters or urine, after touching the patient, and after touching the patient surrounding, which means handrail, linen, IV set, anything. That is the immediate surrounding that they have put. Okay, so what do you think, which is the most often missed step in this? Can you answer? Missed step, most often. Miss is 5, 5, 5, 5, 2, 5, 5, 2, 1115. Okay. So the answer is, many of you have answered it. Very good. So it's fine. Okay. See, asepsis definitely you'll be doing most often because somebody actually will be monitoring. Okay. Before touching the patient, probably most of us are worried of, I mean, that becomes a norm that they're taught that before touching the patient. But most often, if you see, is patient surroundings. Even after touching, they remember. But many often don't have the concept of patient immediate surrounding, which is called the high touch surfaces. Okay, so that concept is important. Patient's immediate surrounding is as badly colonized, and the bioburden or the bacterial burden is high as the patient. Okay, so it's important that if you touch the handrail, IV set, the monitors, the infusion pump, the bedside table, you have to perform hand hygiene. This is again the steps of hand hygiene. You will all be knowing. I'm not going to talk about. There are 6 steps. I'm going to ask you what are the common areas of skip when you do a hand hygiene if it is inadequately done. So what are the common areas that is missed? Do you want to answer in the chat? Some of you are correct. Tip of fingers here. Yeah. Okay, good. So these are the same. Fingertips, web spaces, palm creases. Okay. So if you remember that, you will focus these areas also when you do, because fingertips are commonly, very frequently infected. But when you do a hand rub, before you may not be performing the rubbing the whole, keeping the fingers and rubbing into the palm. So these are often missed. So I usually tell my residents that hand hygiene, how to become a habit means when you start entering the room, you squeeze good amount of hand rub and start rubbing and then go say hello, good morning, talk. By the time you finish the conversation, your hand hygiene is done. And then when you exit again, you take and then we start walking and doing the hand hygiene. Then it doesn't even become a job and you'll not be wasting time. So it becomes on the go. So that's easy and definitely. And how much time do you think hand hygiene requires? Do you want to answer that? One hand hygiene performance requires 20 to 30 seconds. Okay. It is shorter than hand washing. So if you do on the go, it's very easy and becomes a habit. So now, next question. What is the ideal attire for hand hygiene? It's all very well explained. Okay. You want to tell? You can try. To try. Yeah. Exposed up to elbows. Very good. So what with the term that we use is very easy to remember, bare below elbow. Okay. If you are having a full sleeve, wearing a full sleeve shirt, you fold it. Scrubs are best, especially nowadays, especially if you're working in the ICU, if you're a surgeon, and if you're doing a lot of procedures, interventions, all those things. As a resident, you may be on night calls, you may have calls to resuscitate some procedures, CSR. For all this, scrub is the best. Okay. Because you actually can perform hand hygiene and it has pockets. You won't be carrying many things. Mobile will be in your pocket and your hand hygiene performance will be better if your hands are free. Okay, nowadays you are carrying a lot of gadgets also, tabs and so on. So I feel that scrubs are best, especially if you are in a position where you are doing a lot of procedures and you won't be carrying any of this infection back home. That's also important because if you use a full sleeve, you hardly wash and it's hardly gets washed. So coming to hand hygiene, hand scrub. So what is a combination that we usually use is, you should be aware that it is alcohol plus chlorhexidine. Alcohol has a rapid action and it covers almost all but chlorhexidine also, but it has a later persistent action. That is why we combine this. Okay. So that the action of disinfection remains in a hand for few hours. Okay, alcohol is rapid. This is for sustained. And the killing capacity, if you look at, it covers GPC, GNB, virus, all those, including fungi, not spores. Spores are killed only with bleach. And chlorhexidine, again, it covers almost all, though the action against mycobacteria, fungi, is little less. There are now papers coming that this chlorhexidine resistance has been reported, both for MASA, MRSA, and the GNB, but still that's the best option that we have. So this is another last question on hand hygiene. What do you think, is hand hygiene is a choice for the patient? It's a choice to do or not to do, or is a patient right? What do you think? Yes, soap. Everybody is mentioned. So it's patient right. So in Western countries, even here, if the patient are becoming more and more aware, they can even ask the doctor to perform hand hygiene before touching them if the doctor doesn't do. So we should not be put in such an embarrassing situation. So make it a habit. If you are a leader in your team, that is if you're going for rounds, and if you are the leader, if you are performing, all your students will be performing. If you're not the leader, still, if you're performing, whoever is with you will start doing it. You can be a leader, you can be a champion. So hand hygiene is patient's right. So never put yourself in a position that patient stops you from touching because you didn't perform hand hygiene. So clean care is safe care was one year's theme. And it's not a choice, it's basic right. This was put forward in 2005 by the WHO, first global patient safety challenge. Okay. This again is a simple question which we have discussed. Name some highly contaminated surface or objects in the hospital. Very easy. Yeah. Ourselves, yeah. Somebody has mentioned hypochlorite. Nurses had. Okay. Yeah. Surfaces, we are not talking, it's not innominate. Okay. High touch surface is highly contaminated. Okay. So contamination may vary depending on how frequently you clean that surface. Okay. The highest frequency of contact with patients are the healthcare workers' hands. So if you don't perform hand hygiene, it will be heavily contaminated. Others are high-touch surfaces. These are inanimate objects. These are knobs, mobile phones, medical device, BP curves, doorknobs, computer keyboards, which all requires frequent cleaning and disinfection. And environmental surface that needs less frequent cleaning than this is floor, walls, ventilation, ducts, and curtains, where our contact is less and it requires cleaning but less frequent as compared to high-touch surface. So now let us go to what is standard precaution, droplet and airborne. I think most of you know after the COVID, but still I will touch upon. Assume that every patient is potentially infected or colonized with an organism that could be transmitted in the healthcare setting and apply the following infection control. So standard precaution is a set of precaution. It's not only hand hygiene, it includes appropriate disposal of biomedical waste management, also safe injection practices and so many other things. But the most important thing is hand hygiene. So you are assuming that every patient is potentially infected because tomorrow a culture will say that the patient has an MDRO or can develop any other diarrhea or anything which you don't know at that point in time and you may be harboring. So hand hygiene is for all. Personal protective equipment, that is the gowns and gloves that you use, is based on infection transmission risk. Like if the patient has diarrhea or a rash with suspected measles or any viral fever, you may use appropriately. That is also standard precaution. When we identify an infection and put a contact precaution, that is, again, you will be wearing PPE. But even in standard precaution, there is something called transmission-based precaution. That means if you are suspecting a patient with a large wound has some infection, then you are supposed to wear apron gloves. That comes under standard precaution because an open wound will have a lot of discharge. You are supposed to wear gloves and apron. Okay, that is not contact precaution. It is part of standard precaution. So personal protective equipment depends on the nature of anticipated patient interaction. For example, if you are suspecting a patient with a respiratory illness, we don't know whether the patient has flu or COVID. That means you should be wearing mask. So that is part of standard precaution. That is exposure. If you expect something that can result in transmission and is a transmissible infection, then you wear appropriate PPE. Eye protection based on what is the infection risk. Contact precautions is you identify an infection and you put a patient on contact precaution. For example, C. difficile, MDRO, multi-drug resistant organism, which you don't want to get an outbreak and you want patient in separate patient placement, which is a room. You will advise glove, gown, patient transporter should also follow the same protocol. Patient care equipment, that identified high-tech equipment should be separate, like BP cuff, thermometer, etc. And environmental cleaning should be enhanced with disinfection at least 3 times a day. In a known or suspected illness, easily transmissible by direct patient contact, you put all this under contact isolation. Examples are diarrhea due to anything, maybe norovirus or C. diff, or even if anything unidentified, fever with rash, skin wound infection with drainage, lot of pus drain, certain respiratory infection, again, a lot of cough, so it can, the droplets can fall on the linen and your hand can get contaminated. Drug-resistant bugs, obviously. Airborne is the N95 respirator. As you know, it's very famous after the COVID. And apart from that, that room requires special ventilation called the negative pressure ventilation, where the patient should, that room should have negative pressure with a minimum of 6 air exchanges per hour and exhaust directly into the outside or through a HEPA filter where the air is filtered and then recycled. Infection classically under airborne, which produce or droplet nuclei is measles, varicella, and pulmonary TB. And any respiratory viruses who is intubated and a lot of suctioning happening, you have to follow airborne because there will be a lot of droplet nuclei generated. It includes the procedure like intubation, extubation, and bronchoscopy. All this produces droplet nuclei. Droplet precautions generally we use for any patient with respiratory illness, even if it is unidentified etiology. These usually are bigger droplets or fall within 3 feet. So when you are close to 3 feet of the patient and the patient is coughing, wear a surgical mask, that is droplet precaution. Classically, all respiratory infection, including H flu, pneumonia, Neisseria meningitis, diphtheria, pertussis, group A strep, etc. And all the viral respiratory infections. Rubella is a droplet, whereas measles is airborne. So now that's about the basics of infection prevention. I'll come to the hospital-acquired infection. The second half, that's device-associated infection. I'll be talking about mostly. So the 5 major nosocomial infection sites are: 1, bloodstream infection. If it is acquired from the hospital, it's usually through a peripheral line where thrombophlebitis occurs and then patient can have bloodstream infection. Can be due to a central line. I'm not going to detail what is a central line because you should be aware of it. And secondary bacteremia, which can be due to patient coming to the hospital, undergoing an abdominal surgery, getting a secondary infection in the abdomen, and then bacteremia. Or patient coming to the hospital for a surgery, getting a catheter-associated UTI, and then developing bacteremia. These are all secondary, but still these are hospital-onset infection. Then comes the urinary infection, that is catheter-associated urinary infection called COTI. Pneumonia, which can be aspiration pneumonia, it can be without aspiration, it can be a bloodstream infection or abdominal surgery, post-op infections, or ventilator-associated pneumonia. Surgical infection is called the surgical site infection or the SS site. Gastrointestinal infections, which can vary from C. difficile to any of the bacteria, including hospital onset salmonellosis due to the food handlers outbreak from the food handler who is transmitting, who is not vaccinated, is not following proper hygiene measures. All these are possible. But today I'm going to cover only the top first 3 due to lack of time, and as surgical site infections may not be interesting to many of them, I will not be covering that. So again, this is a beautiful chart. I think I got it from Harrison. So you should all be aware. I got few of the information from Harrison. So Harrison has summarized in 1 chapter What happens in a hospital? So this is a basic infection control intervention that is shown in the graph. And if you look at the whatever is shown in the green, it's a infection control intervention. Okay. And if you don't do this, the pathway, the black one of the pathway, that will happen in infection transmission from one patient to another. But you can break the chain by using whatever is highlighted in the green. Okay, so let us start with a normal flora. A patient is admitted with a normal flora and patient is exposed to antibiotics. Okay, and the patient is in the ward or in the ICU. Okay, so then 10 to 40% want to develop MDR colonization. How can you break this? By doing an antibiotic stewardship and restoration of the microbiome. And once MDR colonization happens, 100% of them develop skin colonization, fecal or GI or respiratory carriage. So how can you break this? If it is skin colonized, you can break by giving a chlorhexidine bath in the ICU or in the ward. If they are they can even use the chlorhexidine soap solution or the tissue. If the patient is colonized, 10 to 20% develop environmental contamination. That is, linen, high-touch surfaces gets heavily contaminated. How to break this? By improving the cleaning. That is, housekeeping staff should be doing thorough cleaning 2 to 3 times, depending on whether it is MDR or so, and based on the resources. And adequate cleaning will reduce the environmental condition. There you can break the chain. If 40% of those colonized and due to environmental contamination actually cause infection or contamination of the healthcare worker hand. How can you prevent this? By hand hygiene and following universal gloving, which is not practical. And then if your healthcare worker hand is contaminated, up to 20% develop cause patient cross-colonization. How can you prevent this? Again, by hand hygiene and patient screening and keeping them in isolation, especially if you have an outbreak. Once the patient is colonized, it is very, very variable whether the patient will develop infection. That depends on whether the patient has a lot of lines. If you have a central line, they are more likely to get infection. Again, urinary tract catheter, again, they are more likely to develop infection. If the patient is healthy without any device, he can walk home, but still he can be colonized and he can transmit to the family. So how can you prevent this? By removing the unnecessary lines as soon as possible. And if there is an outbreak, you have to identify all the surveillance and isolate. So this again is a beautiful chart that I found. So now coming to the top 3 device-related infection, which I will with which I will sum up. So this is again a question to you, because I think most of you are practicing doctors. You will have duties in the ICU. So what are CLABSI? CLABSI is central line associated bloodstream infection. So these are the questions which I would like to post to you, and you can try to answer each one of you. You can answer the chat box also. What is the most common site of initial CVC insertion in your ICU? Want to answer? What are the 3 important sites usually? IJV, femoral, subclavian. Is it not? So what are the common things that you find, and you find it's good or bad? Okay, I find most of the answers as IJV. Okay. So the most common site, the preferred site, is subclavian, followed by jugular, followed by femoral, because femoral is the most unclean one. Okay. So if you are using subclavian, if the patient needs dialysis, don't use that. May need dialysis, don't use that. Otherwise, subclavian is the preferred one, followed by jugular. Femoral, if it is inserted, it should be revised in 48 hours, especially if it is inserted in the emergency room, because that carry the highest risk of CLABSI. Okay, the next question is, what skin disinfection prep do you use for insertion of CVC? What do you use? What does it contain? Want to answer? Povidone iodine, betadine. Yeah, any more answer? Povidone, alcohol with chlorhexidine. What is the percentage of chlorhexidine? Povidone, alcohol. Okay. So it is at least 2% chlorhexidine with alcohol. Okay. Just whatever the chlorhexidine that is available in the hand hygiene hand rub is 0.5% plus 70% alcohol. But for skin preparation of a central line, it is like a surgical procedure. It requires at least 2% of chlorhexidine plus 70% alcohol. Okay, please make sure when you go back, you see you're using betadine, please replace because this is the best, better skin prep that should be applied for CVC insertion. Okay. So you should be aware of the strength also. So do you use full body drape when you put a CVC, central line insertion? What do you do? There may be a small drape which will cover the neck, or you can use full body. What do you do? No. Okay. Full body. Okay. Full body. Okay. That's the best thing. Okay. You have to use full body because you will be keeping lot of instruments. So you cannot compromise and the asepsis. So it is always full body drape. How compliant is a healthcare worker to maximize the sterile body precaution? So are they wearing mask, cap, gown, sterile gloves? Or do they? Or no? Do they compromise in any of this? When they put a central line? What does it do? What do you do? What is practice in your hospital? Have you noticed any of the lacunae? Okay. Okay, so maximum sterile because just like you do in surgery, you need all this, remember? Do you use chlorhexidine containing dressing for CVC? Do you use? Have you seen this? When you look at it, there'll be a transparent dressing and around the CVC, there'll be a white patch. That is called chlorhexidine containing patch, which will release continuous chlorhexidine at the site of CVC in entering into the skin for a week. After that, you have to replace. Okay. That is called chlorhexidine dressing. It may be available in different brands. So that is part of a bundle. I will come to that. Do you follow hub the rub before access? So this is something called hub the rub technique. Okay. So whenever the nurses give us an infusion, okay, in a central line, they have to use alcohol swab to rub the hub and then only allow it to dry and infuse because the hub contains a lot of bacteria. Usually they are colonized with. So if you look in audit, they may not do. Then you have to look at that why your CLABSI rate is high, whether this is the problem, and see what can be done. Now there are caps, antiseptic caps that is available that are used, and that also can reduce infection. So let us come to this picture. Okay, what does it say? Portal of routes of infection. Number one, if this is the catheter that's entering the skin into the vein, number one problem is skin organism. Actually, patient can have a lot of endogenous flora. And also over a period of time, healthcare worker hand contaminated, disinfectant, other instruments coming to the skin can be extrinsic and get colonized. The skin gets colonized and then later on can invade the wound. This is the first problem that we commonly is a risk for CLABSI. Second is contamination of catheter hub because it's handled so often for many of the infusions, blood withdrawals and so on. So healthcare worker contaminated can be an extrinsic source of cause for infection, or it can be the skin flora just migrating to the hub because it will be lying on the skin. Third important thing is contaminated infusate, inadequate, improperly prepared solution, fluid, and so on can be manufacturing defect. Fourth is contamination of device prior to insertion. That's also very important. If you don't follow asepsis, at insertion itself, it is contaminated at the skin or while handling. Okay, it's rarely manufactured. It's usually the whoever put in the line or the problem, and there is a break in the asepsis. So our preventive strategies is all focused on this. And when all these strategies are put together, it is called the bundle. Okay. So we have so many strategies that will take care of the hand rub, the asepsis, skin asepsis, hub the rub, and so on, which will be called as the CVC bundle. Okay. That I'm going to show you in the next slide. So there are several risk factors for CLABSI. The most important thing is those with a CVC and they are in acute care or vulnerable population, that is dialysis, who have long duration of catheter, chemo patients, and so on. And even in pigs, we have seen infections majority, especially if it is not handled well. There are several patient-independent risk factors, which I'm not going to detail, but whatever is in the black, no, that cannot be actually modified. The prolonged hospitalization, neutropenia, obesity, prematurity, TPN going, blood products, all may be required. But whatever you see in purple and blue, that can be modified. That is how we can bring a behavior change. That is, you can remove unnecessary catheter, you can reduce the colonization of the insertion site by using the chlorhexidine patch. And at the hub, you can do the rub the hub technique. You can avoid multi-lumen to single-lumen catheter. Double catheters can be avoided unless the patient is on dialysis, improve nurse to patient ratio, and you should not be manipulating much. So as I said, there are certain interventions if you put together, it is called the bundle. And unless you follow all the aspects in the bundle, you cannot achieve CLABSI reduction. So I am going to touch upon 3 articles that was recently published, and this is the latest on the CLABSI prevention bundle. So this is updated in 2022. It's a freely available. It's called the SHE IDSA EPIC Practice Recommendation to Prevent CLABSI. If you are a practicing doctor and you are handling CVC, this is a must. Please download and keep it in your mobile. So the headings of 4 essential practices that should be adopted by all of you. Additional approaches: when your CLABSI rate is high, you may add something more to prevent the CLABSI rates, that is infection rates. Something should not be considered that I will touch upon, and we don't have much evidence for some. That's called the unresolved issue. So I'm not going to detail about it because it's available online. So the essential practice again is divided into before insertion, at insertion, and after insertion. Okay. And before insertion, everybody should be trained, and you have to see the necessity for insertion, and you have to have chlorhexidine bath and so on. Skin preparation. At insertion, everything should be in place. You should have a checklist, and the whole process, that insertion thing should be bundled up and should be kept ready. The objects all. So you should not be searching for something that's not in the kit. Hand hygiene, again, it is like a surgical scrub, not a simple hand hygiene, surgical scrub. And subclavian site is preferred. All-inclusive catheter cart should be ready. Ultrasound guidance can be used, but still you should not compromise the asepsis. Maximum sterile barrier precautions, full body cover, as well as mask, cap, everything is required. Alcohol, chlorhexidine, antiseptic. That's what I was discussing. 2% chlorhexidine. After insertion, what do? We should maintain nurse-patient ratio, chlorhexidine containing dressing at the CVC insertion site. It should be avoided in newborns because it can cause toxicity for the newborn because of thin skin. And change dressings not very often. You can change once in a week or soiled. And at each contact, you have to disinfect the cup. That's very, very important. You have to remove non-essential catheter. Routine replacement is necessary only if you infuse blood products. The infusion set should be replaced. And surveillance to know whether your CLABSI rate is higher. So again, this is the picture which shows that subclavian, femoral, and the jugular PIC is also shown. So subclavian is the preferred site. Okay. And use maximum sterile precaution as shown here. Cap is must, mask is must. Because you can shed MRSA, you can shed other bugs that you colonize in the nose and contaminate the field. Full body drape is a must. Alcoholic chlorhexidine, I again discussed, 2% chlorhexidine, and it should be allowed to dry so that it can act, and not in newborn patient. Okay, you should remove non-essential catheters. Again, we have touched upon. So, but that should not be practiced is do not use antimicrobial prophylaxis for short-term or tunnel catheter insertion or while catheters are in situ. Just because a patient has a central line, don't give antibiotics because they are at risk of infection. And don't replace routinely. So this is again a post-test. Now I think you will be able to answer all the questions which we have discussed. I'll go to COTI. Again, this is an update which is published in 2022, SHE IDSA EPIC Practice Recommendation. And this is a beautiful diagram which you can all capture and see. This is a conceptual model of COTI prevention. We have to disrupt the life cycle of urinary catheter. That's what they say. Okay, what is step 0? Avoid hand indwelling catheter use if there is an alternative, in and out or anything, condom drainage if is voiding. And then once you insert catheter, asepsis is important and it minimizes the injury. Once inserted, maintain by closed system, hand hygiene and secure positioning. And avoid urine testing asymptomatic bacteriuria when the patient is catheterized, have a cloudy urine. You should not test unless the patient has fever. Cloudy urine may be due to different cause. Remove the catheter when it's not necessary. That is step 3. There can be catheter removal reminders, stop orders, and nursing empowerment as well. So this is what they say. Education, training is important for competency. And you should not do culture unless it is necessary. And insertion, ASEPS is important. And intermittent catheter may be an option you can try for certain patients. And always have a help. You don't do a catheterization independently. You will need another person if you want to perform aseptically to help you when insert and actually perform the catheterization. And once inserted, there's a whole lot of list of management of indwelling catheters, okay? You have to secure it with a plaster and you should not break the closed drainage, okay? Always keep it sterile. And when you are collecting, you should be freshly inserted catheter is preferable. Change the catheter and then only check for culture if you're suspecting UTI. Otherwise, you will culture colonization. Unless the patient has symptoms, don't do. That is fever or abdominal pain or something suggestive of UTI. Okay. And don't obstruct the urine flow. So when you're taking the patients for any imaging also, make sure that it is always below the bladder and it's not kinked and it should not be overflow. The bag should not overflow more than 3/4 full. And the bladder bag should never be above the patient's bladder. The bag should never be. Otherwise, there can be reverse flow and that should be, that can cause urinary infection. Okay. And meatal area should not be cleaned frequently with alcohol or anything. It can burn. Routine cleaning is required. That is all. I'm skipping this. If you have increased COTI, you can follow these things. But if you can download the document, that will be good because there are a lot of many information in this thing. Okay. And one more thing, catheter irrigation is not routinely practiced unless there is a block. Don't do that to prevent infection. You can cause harm by doing that. Okay. Even if you are doing catheter irrigation, it should be closed irrigation if there is an obstruction. And don't give antibiotic just because the patient is on catheter. Okay. Now I go to the VAP bundle, the last one. Again, it's a share update. So this is important. Some important things that you have to notice. Okay, NIV is better than invasive ventilation. Go ahead and try that first. Minimize sedation, improve physical condition, chest physical rehab, elevate the head, provide oral care. This is very, very important. Earlier we used to give chlorhexidine, now toothbrushing without chlorhexidine because they have found that chlorhexidine can cause harm. Provide early enteral feed and ventilator circuit should be changed only if it is soiled. Otherwise, not routine. Okay. Then use these are all additional approach which I am not going to talk. So most important thing is this chlorhexidine mouthwash is replaced with brushing. Okay. And with that, I will stop and I can answer questions. So
yeah.
That should
Thank you, Dr. Raji, for the wonderful presentations. I know infection control, we can keep on going. It's not a one-hour presentation. This is even one day is not sufficient to discuss all the aspects. We need to cover the basics to top, I know. So our second part of the program is like we usually start doing the post-test, whatever points we discuss, whether the people got the points or not. So the post-test we are running now.
Okay.
So by the time we can go through the questions, we can have the Q&A in the last 5 minutes. I think today we have a little bit of overshooting of time is possible there. I just check it's not running on. Low or my net is good. Not good. Yeah. So we are putting the essentials of HAI and DAI, what Dr. Raji has just wonderfully discussed. Almost all the points. I'm going to a couple of posters I'm going to run. Why this posters? Because AP and ICP wanted whether he got the points or not, and we running the detailed examinations after the course is over. That's fine. So to stimulate to your understandings, and I want to check how many people are still awake. Almost 90 odd people are still there, and some of the people are YouTube. People are messaging me and not able to log in now. That's fine. So who is the most dangerous people? Whether you, the patients, or both, I do not know. So I want to check how many people are answering out of 95 people are there. People say both. So healthcare workers and your patients. Okay, both only people are answering. It's good. Typical call, but what the data shows, you need to see the data also. What the data shows, usually you're getting more infections or more infections from your patients to you. That depends upon the width of the arrow. The width shows patients can transmit more to you compared to you transmitting to the patients. So the answer is both is correct. So, but you are getting more infections from your patient. Keep in mind, that's most interesting for you. So this is the CDC data I'm showing to you. The next questions I'm going to ask you is why this is happening there, why this infection control talk, why we keep on separate sessions for medicine PGs and DNP PGs. Our occupation carries high risk. We know, everybody know, traveling in the flight is high risk, we know, but compared to traveling in high risk, pilots, we are also at high risk category only. Don't think we are a safe category, we are in high risk category only. So why this high risk category? Because we need a lot of behavioral changes. Treating infectious disease is the easiest part for me. Preventing an infection is the most difficult part for me. If you understand the infections control and infections preventions, if you master it, treating infectious disease is nothing. You can make a diagnosis, you can treat it there. So this is the impact. People are doing infections control, the look will change. This person is called Ignatius Semmelweis, who found out the 5 moments of hand hygiene, or at least hand hygiene is essential to prevent infections. He demonstrated in 1840s, not in 2020, but within 5 years, this look has changed and finally died in mental asylum. People say this is a old, outdated data. Right now, this is a current data. Before my infections control, after my infections control. So changing behavior is most difficult. Infection control involve a lot of behavioral science. The look will change. When people ask why infection control and need recessions, people come for some simple surgery. For example, this person came for a cardiac bypass. Ultimately, he lost the limb because of the poor infection control or poor hand hygiene. That is the reason we need to learn infection control. Otherwise, your patients will lose their life and you're not going to come back to your hospitals. Not only the patient lose their life, even during the COVID wave 1, lot of doctors, this is a publication from Tamil Nadu Medical Journal. I took upon it. Doctors lost their life. I not put classes, I didn't put housekeeping stuff, nothing. So this is a number of doctors died during the first wave of COVID between May to June or March to June, I can put it. So this is a number of doctors died. Why? Because they don't assume everybody is infected with COVID. That's the main reason. That's called the standard precautions. Okay. Now post-testimony, why I need the infection control sessions, I enlightened to you. How many hospitals follow these practices? Before the ICU, no shoes behind this point. And we want to remove the shoes. How many say this is a correct policy? Yes, this is a correct policy. I need to adapt. No, I don't want to remove my shoes. Or it may be selected situations I can do. People say no, but if you go to the most of the hospital, they say remove the shoes before entering. They kept a separate counter. People say yes and no. So what is the data for it? Raji has beautifully covered this one. How the infections transmit. There's a reservoir and the person should have some hose. How it is transmitted. It is not jumping from the floor to the patients. For example, if you're walking with the blood issues or something, whatever mud you're carrying to the ICU, it won't jump to the patients. It won't jump to the patients on the surface. But what happens if you start wearing a shoe cover, you are carrying the bug in the hand. If you are wearing the shoe cover, that point of time you contact the sole of the foot and carry some bacteria. And if you don't do the hand hygiene, you are going to transmit the infection to the patients. That is why we say shoe cover is not required and increases the cost and disposes also cost. People want to know what is the evidence. So usually we show one of the evidence conducted in India. People say Western country, the roads are clean. But if in Indian country, this is from Armed Force Medical College, Pune, they demonstrated wearing a shoe cover and without shoe cover or changing the shoes, there is no impact on the environmental contaminations. What is required is we need to clean properly. We need to clean environmental cleaning should be taken care. This is for aesthetic reasons, not for the infection control reasons. So if we know the basic differences, why we are doing infection prevention, that is very, very vital for you. We need to understand the concepts of infection prevention. That's why she clearly put how the bacteria is transmitting or how the organism is transmitting in the infection control part. So we need to know the basics. Once you know the basics, then only it's easy for you to apply the knowledge. So you can't say why the shoe cover is not required. Paper is there and we can't jump. Bacteria cannot jump from the floor to the patient. That's most important thing. Find two errors in this isolation practices. She talked about the isolation practices. What isolations first you can tell? Just put it there. Isolation practices. I want to check how many people got the point. What she discussed about it. What isolation she touched upon it. So I mentioned it about. We can use shoe cover. No. If you use shoe covers, it increases the bulk and increases the bacteria. There is no need for it. So your shoes won't be transmitted. I think people are not answering to this easiest question there. So what happened to you people? Want to get attendance or not? So just go ahead. So touching the patients without PPE, gloves, mask on nurse, not gloves on the patient, not the person. So tell what is the thing? So she's not wearing any glove there. So what error you find out? Two errors. First thing you tell what isolation practices. Seeing the patients, what is your diagnosis? Person is a thin built, malnourished, and patient is struggling for breath. So most probably the person is suffering tuberculosis is a likely diagnosis there. Once you think the person has got tuberculosis, what isolations you want to put and where is the error? TB is a diagnosis, excellent. But what error in the isolation practices you can find out? People are still say TB, that's fine. But what is the error in infection control? I know you're all clinician, that's why you are in the sessions. Mask, what mask is an error? So we need to know their personal protective equipment. I told them we need to understand the infection control practices. We need to understand the personal protective equipment. For example, if you are wearing an N95 mask, what it does? It prevents entry of organisms into you. When you're wearing a surgical mask, it prevents organisms coming out of you. For example, the surgeon operating during their surgery wear a surgical mask. Something should not come out of his mouth. On the other hand, if you wear a N95 mask, something will not go into your mouth. That is most important thing. But what happened, this person already tachypneic. If you put N95 mask, everybody knows during COVID time, if you start wearing N95 mask, what happened to the patients? So already the person has got very poor reserve. He'll land in intubation shortly. So if you want to transfer the patient, that point of time, cover the nose and mouth by wearing at least surgical mask for the patient. If you are transporting the patients, if you are keeping the patients in isolation room, particularly negative pressure room, there is no need for patient to wear something. Unless the person healthy, we can protect you from coughing out. Yes, we can wear surgical mask as an option. We keep the person in isolation room, particularly negative pressure room. There is no need for mask for the surgeon unless the person is stable enough to wear a mask. But the nurse should wear N95 because she should not get into thing. That's most important thing. Here, both the persons wearing wrong PPE. So understand the infection control chances and prevention. It's most important thing. That's the point he made it. So this is airborne isolations. What is required? You need to follow it up only for TB, varicella zoster, measles, varicella zoster, measles, these type of infections, we need airborne isolations. Can you identify? Again, she touched upon it there. Clearly discussed in detail also. CKD patients admitted for hemodialysis. They're planning to insert a central line. Find the error. Can you find the error in this case? So she touched upon in detail. I want to see the responses. Okay. Sanitation is not enough. Okay, that's major thing I know. Full body drape, but so yeah, your point is well taken, Rajesh. They understood the points. So this is what we need to do. So inserting a central line is equal to doing a surgery. So when you insert a central line, you just not put the glove and insert the central line. So we need to cover both the patients with the drape, and you need to also behave like a surgeon while inserting and try to choose the site may be ideal subclavian, but very difficult for juniors, at least jugular. In emergency, if you put femoral line, try to remove the line at the earliest. That's most important. Once the emergency is over, try to remove the line. Don't keep the line and pushing the lines. So this is very important. So which part of the bundle is wrong here? The person received Foley catheter. She touched upon both insertion bundles and maintenance bundle. All posters is based upon the speaker's presentations only we are putting it. We are not asking anything extra. So unless you listen properly to the speaker presentation, it's a bit difficult for you to answer. People say either 2 or 3. Most of the people say 3, both insertion. We do not monitor the insertions. So you can't put both. This is only I put the picture while after the insertion is over. Insertion I have not taken any pictures. So this is basically a maintenance bundle. What is the error? Anybody can go and type. What is the error here? So what is the error there? In maintenance bundle, you're saying maintenance bundle, it's fine. Usually what happens is maintenance bundle for a catheter. So this is an ideal situation. It should be unobstructed flow on dependent positions. Here the Foley catheter take a U-turn, go up and come down. So what will happen? Stagnations can happen. So we need to have a unobstructed flow. That's most important. Inserting is one part, but maintaining the catheter is the most important. Whether central line or urinary catheter or ventilator, handling is most important. People forget. Even doing the surgery is a difficult task. But once the surgeon do a utmost care, the nurses handling the surgical side poorly will get infection. So maintenance bundle is carry equal value to the insertion bundle. That's the point we are making here. So now come to the case studies here. I think a couple of microbiologists also joined today. 10-year-old child admitted with a fever and joint pain. Blood culture was growing gram-negative bacteria. Usually, some of the bacteria, particularly GNB, is very difficult to identify. The practice in the microbiology lab, they start smelling the culture plate and finding the organisms. So with the smell of the bacteria, they can tell what bacteria it is. Experienced technicians can smell the culture plate and tell what organisms. Couple of lab technicians and microbiologists smell the cultures, immediately identify the organisms. They identified also. One of the lab technicians is pregnant. 13 people were working in the lab. Finally, the Malrikov, they said it showed brucella. So basically, they smelled the brucella culture plate. Once you smell the brucella culture plate, what will happen to the persons? Any idea? What will you do now? This is most difficult. So we need to know certain prevention measures, not only the basic things, but we need to know what to smell, what not to smell. I told a lot of people lost life in COVID because they didn't know standard precautions. All patients carried that point of COVID, they failed to recognize. So people say two, follow them for 1 year. So this is a bit difficult task of what we need to do. So this type of situation, this is called post-exposure. In the hospital, a lot of exposures can happen. If we follow infection preventions, we can prevent the exposures. Even if it has happened, we can prevent it. So what we need to do, so this is what risk assessment. Any exposures, any outbreak, do the risk assessment. What is high risk? People who smell the culture plate, they got high risk. People who stay within the 5 feet distance, the risk is also there. So we need to know the risk categorizations. Any exposures, any outbreak, always think what is going wrong. So don't shout and immediately act. Do the investigation. That's most important thing. So this is a real case scenario, not cooked up scenario. We published a paper. 13 people exposed. People smelled. The pregnant lady, we are given alternate things, but fortunately she didn't smell the thing. So we have taken the precautions. We given a doxycycline. We monitored the patients. They improved well. So this is another interesting stuff. Where to place the patients. This is a 6 months old African infant came for cardiac procedure. Finally, they diagnosed congenital rubella. Admitted with the PDA corrections in general ward. The interventions was failed. Cardiologist tried but failed. Underwent surgical corrections. Stayed in CT ICU. Completed the cataract procedures because he has got cataract also. 2 nurses and 1 PG. Almost 30-35 people are providing care. 1 PG and 2 nurses were pregnant. Is there any outbreak investigations required? Just congenital rubella exposed healthcare workers. What will you going to do? I want the responses here. This is all bit difficult. So we need to know where to place the patients. You want to get protected. What the people start Googling. Very interesting. Google cannot give the answer, I'm sure. Find the Google answer and put the Google answer to me. Even ChatGPT can ask for it. So put the answer. People are saying Googling it there. So this is congenital rubella. Yes. So they want to do the outbreak investigations. So we need to know how the disease is transmitted. We clearly put how the diseases are transmitted. So this type of scenario, this congenital rubella is transmitted both by contact as well as by means of droplet. That's possible. So when the person is providing, they are exposing large amount, up to 9 months or even 1 year, congenital rubella child can excrete the rubella virus to other people, not only through the skin or not only through the droplet, also possible. So this is also again an exposed case. We analyze the data. Fortunately, the pregnant ladies, rubella IgG was positive. She was immune to the rubella. So we need to assess whether they are immune or not. These things we need to do. So this is called outbreak investigations or something. When exposed to the thing, we can prevent. Infection preventions before happening also we can prevent. After the exposure also we can prevent, that we can keep in mind. So this is my last post-test questionnaire. Housekeeping staff employed by an outsourced agency entered a deceased patient room to clean. Claimed to have sustained needle stick injury while cleaning the room. Overheard doctors were discussing that the patient had HIV. No pre-employment check because this is outsourced agency, so there's no pre-employment check. Incident report was raised by ICN promptly. Did HIV, hepatitis B, and HCV. HIV report came back positive. The person brought the needle. This is a needle. I got a needle stick injury. What will we do now? So these questions again will give extra marks for the people who answer and solve this question there. So in the post case, we can give a lot of extra marks for your final examination, not today. People say suggest 3 or 1, 2, 3, 5. Do detailed analysis. Test the source patient, but unfortunately, there's no sample available in the lab. The person already deceased. What will you do now? Anyone provide the answer here? Take care of the medical expenses. None of the hospitals willing to take. The second choice is most of the hospitals willing to take. So people say 5, detailed investigations. So the problem is when the person has got needle stick injury, we need to do the baseline test. If we do the baseline test, that indicates the person is previously infected or not. This housekeeping guy is a very intelligent guy. He want to claim the benefit from the hospital. So what he did, he claimed the deceased person has got HIV, a sustained needle stick injury. By the time the dead body has been shifted out and patient is moved out. So he thought he's not going to escape with it. But ICN did the baseline test. The baseline test is positive, means it has got an window period is there. So the person immediately came and showed me. So what it is, we need to report. If the person is reporting, do the baseline test. Baseline test is positive, indicates 4 weeks before itself the person is infected, at least 2 weeks before. It saves lot of money to the hospitals. This is how we need to apply our knowledge. So what is an incubation period when the person is exposed? What to do? These are all the infection control aspects we need to learn practically before solving the things. That's what required there. So with this, we can close the post questionnaire. If you learn infection control, treating infectious disease, managing infectious disease is nothing for you. So you need to learn a lot of things. So a lot of things we provided in the conferences, what we provided. So those who want to learn, we can learn and join them. So I right now open up the posters questions. I think we are now 8:40, almost 10 minutes for our next 5 minutes to wind up. What is the role of full sleeve apron, Dr. Raji? Is there any role for full sleeve apron in the hospital?
Full sleeve apron for only for contact isolation and in asepsis like OT. Otherwise, you mean the coat that is worn over the regular dress is not required. It is only for contact isolation and in asepsis where you are doing a procedure. Those are the conditions where full sleeve apron.
People are asking about this. I agree with you. The full sleeve, particularly for nursing staff, those who provide close contact care and those who are operating, those are inserting a central line. Otherwise, not for everybody there, not for every situation. We are generating a lot of waste also there. What is the fumigation efficacy and what is the frequency we can do in ICU?
Okay, we don't do fumigation, but there are other actually environmental services that is currently available. So fumigation uses chemicals that can harm the person who is doing that. So it is actually CDC has removed its guideline for fumigation. In certain condition where you have to, you have to do a thorough cleaning of all the high-touch surfaces, whatever be that is called the terminal cleaning. And now more and more UV is being used, especially after the COVID. This UV is actually robotic, automated. It can, you can time it and it does a very good 360-degree cleaning. If you can, do the exposure time and all those things setting. Then there is something called the chemicals that are used now, more of hydrogen peroxide based and so on, which is less harmful. And these liquids are now used for more of, it causes mist, similar to fumigation. That is what is being practiced. But again, only in limited situation, not in a routine basis. So if you do a thorough terminal cleaning with disinfection and allow correct contact time, that is good enough. And rarely do we use fogging in the current scenario.
In follow-up of these questions, again, what is your hospital practices? Are in operation theater completely fumigation free?
We don't do fumigations, but if we have an outbreak or anything, a new OT after demolition or something is done, then it is used. But again, we don't use the toxic chemicals. So in certain hospital, I have learned that on the everyday, after all the cases over, they do fumigation, but we don't practice that. But we are thinking of buying UV.
One more the basic question is, what is the difference between the fumigations and fogging?
Okay, so this is, it's both are mist forming, chemicals forming the mist. Both, depending on the chemical, it can be toxic. Okay, and now less and less toxic chemicals are available. We have stopped doing both. Fogging was what, fogging can be used outdoor also. If you look at many of the chemicals that is used for even the vectors, those are all fogging. A large volume of chemicals is used, and even it is used in outdoor environment. I think Dr. Suresh, if you want to add or clarify for that, anything.
Usually, like a fumigation is more of vapor. That's why we need to completely close the room, and fogging is more of mist. It go deposit in the surfaces. Difficult to clean surfaces, we can use fogging, and fumigation is usually. People are asking even after the infective case. Yes, Even after the infective cases, fumigation is not required. That's what CDC, WHO, everybody has removed the guidelines. But surge and mind, because previously people used to do formaldehyde. Formaldehyde is a carcinogen. If you do fumigations, your risk of getting carcinogenicity is very high. People are using quaternary ammonium compounds. What we found in quaternary ammonium compounds, your instruments got rusted early. So if you want to preserve life of your instruments, avoid these practices. Give idea to clean properly. What she mentioned clearly, terminal cleaning. Clean all the nook and corner. That is more important rather than fumigations or fogging. That's not going to help out. Then couple of questions on OT surveillance or environmental surveillance. What do you recommend in operation that you are saying fumigation is not required? How to monitor my OT is clean? What surveillance you are doing in your OT?
Okay, so surveillance is required for outbreaks, and in OT, yes, you can do air sampling. That is by you have to get a good instrument standardized, because how it is done and read is all standardized. So your microbiologist definitely knows better. They may be doing so air sampling is better. Settle plate is done. Again, that is again should be done in a specific way, without much of interruptions and door openings and so on. Mostly it's air sampling.
Good. So same thing there. We need to monitor the air rather than the swab. That people are doing swab surfaces. Usually, in case of outbreak, yes, we can do. Otherwise, there's no road for surface surveillance. We need to check the air surveillance and scrub water surveillances. People always do. These things is very important. Instruments are monitored by the CSST department. That's fine. And third thing, people are asking about the dialysis water surveillance. What are all the things you do in dialysis water?
Yeah, again, it is dialysis is done on a monthly basis. And the most important thing is the endotoxin level. Okay, so this is a specific level that is monitored and reported, which again microbiology will keep track. And if there is any outbreak, then the water cultures are also done monthly. And if there is any outbreak of pyrogenic reaction in a dialysis, that is when you may start doing culture and endotoxin levels. That means your filter at some point, either filter or the supply may be a problem.
So this is the most difficult thing. Again, we need to answer. In government setup, we don't have a alcohol or sterlium or chlorhexidine based hand hygiene available to me. How to do my hand hygiene in government setup?
Okay, alcohol is very cheap. Chlorhexidine may be costly, so alcohol should be available actually. If it is
even
nothing,
that is not available there.
Then soap and water.
So every time go and do soap and water is a bit difficult. As rightly pointed out by couple of government hospitals, they use the clinical pharmacology department to prepare their own disinfectant. That's what most important. That's very cost effective. Your hospital need to show. Your administration should step in and do. The second part is, if it is not available, you can use as a personal conscious. You can get a small hand drop for you. That's the better for your. That's the better for you. That is also not possible. Hand wash is the last solutions we can able to provide. People are asking, or we can prioritize also, because government sector, we know a lot of things is not available there. So we need to prioritize all aseptic procedures. At least you can do. That's why you can put it there. There is no correct answer. The correct answer is easy, but administration should show interest. Otherwise, it's a bit difficult for us. And people are talking about what is Suiman step in hand hygiene. SUIMAN, they put it there. Yeah.
What is it?
SUIMAN, Suiman steps in hand wash. What is Suiman steps? Usually it's a mnemonic for the steps. For example, start. Start like a part, rubbing your palms, doing like above the palms. That's a steps. That is SUI. I stands for interlacing. Mnemonic for the 6 steps of hand wash there. So that is a Suiman. That's nothing different there. So if you do Google, they find out there. People are asking about chlorhexidine disc in prevention of the epilepsy.
That I have mentioned. I have mentioned.
So before that, you do proper insertions, proper maintenance, take care of your hand before these type of costly interventions. People are asking for a neonate. If chlorhexidine is not useful, what agents are using it?
See, they have the guidelines say that if benefit outweighs risk, you can use. So beyond 1 month, definitely. In preterm, better avoid. Second is they use only, they don't use any alcohol or anything, but they have tried octinidenone. That is for scalp, neurosurgery and newborn. They are less toxic. So brands are available that can be tried.
Yes, usually povidone is safe. We can use in the children, but if you want to have octinidenone, is a better choice. Chlorhexidine for the mucosal surfaces also we need to avoid. For again, that point of time we are using povidone or octinidenone. There also we can use it. The questions keep on coming. For example, couple of questions about the method of water surveillance, everything. We'll update you. This is a one session dragged up. I thought the sessions will wind up before 8 o'clock because this is infection control. People are not interested medicine PGs, but still 100 people till the presentations. And all the presentations is over maximum 8:38, 8:40. This one went up to 8:50. People still asking for the questions. It shows a lot of interest, and you created an interest, Raji, without
Thank
any
you, thank you.
things are further. Like you keep the people engaged and keep asking. Whatever questions you put it in the chat box, we'll send it to the speaker, and we'll get the presentations also. Keep ready for examinations going to happen in July. There are another couple more sessions is getting over the certificate program. I sincerely thank Dr. Rajiv. Despite a busy schedule, she spent the time and created interest on infection control to the medicine PGs one. And second thing, I need to thank AP and ICP for providing this wonderful opportunity. And I thank the media team for providing this Google link. And I thank the participants today. Nobody mentioned the name to get the attendance. Instead of being the participant and get the attendance, that's a good sign today. And third thing, people are keep the mute. That's also sign. Without further ado, we close the sessions. Thank you one and all for this wonderful presentations. Thank you everyone again. Once again. Bye.